Good evening, friends. Welcome back to Pediatric classes. So, what are we going to discuss today? Let us discuss about skin prick test and also its role in the diagnosis of allergic disorders. So, let me start sharing the screen. I hope all of you have subscribed to my channel. If you have not yet subscribed to my channel, please do subscribe and support the initiative. So what are we exactly discussing in this particular session? So here we will be discussing about what is allergy, what is the difference between atopy, sensitization and allergy, what are the basis of skin prick test, and what are the indications, procedure and interpretation of the results of SPT. At the onset, I want to thank my faculties of the diploma in allergy and asthma of CMC Vellore, where currently I am doing the course. So all they have actually played a major role in me understanding all these concepts clearly. So allergy, as you all know, is an altered or exaggerated body response against harmless substances called antigens with the production of IgE. That is, immunological response is involved, which can be either protective or harmful. Okay. These are the terminologies. One is atopy, sensitization, and allergy. So these concepts has to be very clearly understood for understanding the further things of skin test. So what exactly is atopy? Atopy is a genetic state. Suppose the father or the mother or grandfather, grandmother, somebody in the family is allergic. So that means we can say the child is having a history of atopy. So this is a genetic state. Okay, it is a conferred state to a child. Whereas what is sensitization? Sensitization is an immunological state. That means one of the time there is an exposure has happened and the body has reacted by producing some IgE. So actually sensitization detects the presence of IgE onto the mast cells. And what excites allergy? Allergy is a clinical state. When they have symptoms of allergy, it can be itching, it may be breathlessness. All the symptoms of allergy happens. So atopy is a genetic term conferred by virtue of the parents or grandparents having the allergic illness. Sensitization is an immunological term. The child may be sensitized to a particular allergen after exposure or allergy, but allergy is a clinical term. That means they have suppose the child manifests the features of allergy after re-exposure to allergen. That means the child is having allergy. So these are a few questions I got. A child can be atopic but not allergic. What is the answer? Yes, it is true. That means father or mother is somebody's allergy. That means child is atopic, but need not be allergy. Child need not be allergic because child need not have a symptoms of allergy. A child can be sensitized but not allergic. So these questions actually Vedantan sir has asked us many times. So thank you so much, Vedantan sir, for this wonderful questions. So a child can be sensitized but not allergic. So that means a child has got the propensity or has been sensitized, but child is not developed or had symptoms of allergy. Again, it is true. A child can be allergic but not atypical. Yes, many times you would have heard that the children are having allergy, but there is no family history suggesting of that. So that is also true. And the fourth is child if allergy is always sensitized. Absolutely true, because without sensitization, the child will not have the symptoms of allergy. So why are these children more prone for allergy than adults? So one is about the risk of exposure, even transplacentally and through breastfeeding. And they tend to inhale more pollutants per kg of body weight than do adults. And airways of the children are very narrower compared to the adults. And they have this exploratory behavior in the children, which is having related to more exposure. And this particle size also matters. As you all know, less than 2.5 size microns may reach the terminal bronchioles and the alveoli, leading on to the symptoms of bronchoconstriction and breathlessness and other things. Whereas the coarse particles 2.5 to 10 microns get deposited in the upper airway tract and large airways. Thank you, the team IAP also for bringing out wonderful classes on this allergy. And let us now discuss about the 3 types of skin test, which you do for allergy. So the first thing is skin prick test. This is the primary mode of skin testing for immediate IgE mediated allergy. Very widely practiced, carries very low risk of side effects, provides high quality information, and this can be actually shown also to the patients. So there's another test called intradermal skin testing that is also for immediate IgA mediated and also for delayed type hypersensitivity, but it is comparatively more risk of adverse reaction compared to skin prick test. It requires high levels of technical and interpretative skills also. Yet another testing is called patch testing that is actually helps to detect the contact hypersensitivity and some other forms of delayed type of hypersensitivity. And generally, most of the time, this patch testing is done by dermatologists, and this is not relevant for immediate or IG-mediated allergy. So I just put this slide to make you understand what exactly happens in a type 1 hypersensitivity reaction. The antigen gets engulfed by the antigen presenting cells, which can be a dendritic cell or a macrophage. Then what happens? This antigen is presented with the help of T cells to the B cells, which stimulates the B cells to produce IgE. These IgE will go and get attached to the mast cells, and this will actually be there. So what happens when the second exposure happens? There is this antigen will come and this coupling of the IgE happens, and then there is release of mediators. There are all the symptoms of allergy happens. There may be itching, there will be rash, redness because of the mediators. So what exactly are we doing in this skin prick test? This skin prick test, we are actually assessing the bound IgE over the mast cells at the point of entry of allergen into the skin. So these are two scenarios. One, like we need to actually decide where to do an allergy, where not to do an allergy test. So if a child comes to you with recurrent cough, cold, but gets an episode once in 20 days, recovers after 1 week, child is normal in the interval period, no family history of atopy, such things in there means we can actually hold an allergy test. No need to do an allergy test. Whereas in a case B, sorry, we get a child with 6-year with recurrent cough, cold, and fever for 15 to 30 days, sneezes every day in the morning, and gets wheezing during fever episodes, and also has eczema. Father is non-asthmatic. Such cases where there is a known atopy, there is history is there, and child is having symptoms pertaining to allergy, please don't hesitate yourself from doing a skin prick test. So these are the places where children we do allergy skin test in cases of allergic rhinitis, atopic asthma, allergic conjunctivitis, moderate to severe atopic dermatitis, food, insect, drug allergies, and if there's those children with history of anaphylaxis. These are indicated in all IgE-mediated allergy clinical situations. So what are the antigens we are going to test? We are testing, what are this image I have shown you? These are the dust mites. So we are actually, this dust mites, there are millions and millions in there. They may be there in the beddings, it may be there in the pillows. So many times this is found to cause around 50% of the allergies. So we have to be very careful. We have to do the skin prick test. When we do the skin prick test, we can actually put this as one of the antigens to be tested. That is dermatophagoids staphylococcus and dermatophagoids farinae. Then we should be testing generally one of the antigens which we test is a cat dander and the dog dander. In this point, I want to say one thing that is like a cat is like, once a person is allergic to cat, he's allergic to all the cats. So there's no question of him having another breed of cat, but it is not possible. But dogs are actually species specific. Then cockroach is one of the major allergens, BLG1 and BLG2. Then we have that, then all these pollens and all are like major allergies. So we generally test them also. There is Sandium, Strumium, Prosopis, etc. I have actually put the images of it. This is Cynodon, Dactylion. Then Malayalam, it is called Karagapulla. Then this is Prosopis julifera. These are all like very commonly seen in our setup. Sandium, Strumium, etc. This is actually called Chota Datura. So we can actually choose the pollens according to the pollen calendar and get the patient tested also. Rather than doing a blanket study of all the antigens, choose the appropriate antigens, do the test wisely so that you can be easy to interpret the results also. These are the common moles with test. There is Alternaria, Cladosporium, Aspergillus, Penicillium, etc. So house dustmite is found to cause approximately 50%, pollen 20-25% people, mold 7-10%, insects around 10-20%, animal general less than 5%, etc. So one of the major thing we should understand is SPT dictates only sensitization. That means it actually dictates then whether bound IG is present over the mast cells or not. So it is actually a test for sensitization. It does not diagnose clinical allergy. So SPT is an immunological test, not a clinical test. So before the procedure, we need to do the history and physical examination of the patient, take an informed consent, and main thing to note here is we have to avoid antihistamines at least for 3 to 5 days. Make sure that when you actually tell them, oral steroids are found not to alter the results of SPT. And so many people, when we say stop the medications, they may tend to have this idea of stopping the inhaled corticosteroids. But may you make sure that you are telling them properly, clearly that inhaled corticosteroids to be continued if the patient is on ICS. So skin prick test, we have got all the bottles of allergen ready. And so there are so many bottles here now, you can see. So there are lots of allergen bottles here. So main thing is like we have to arrange them properly in a order because we will be actually like putting one drop of it or minimal, very less quantity of it you need actually you just put on the skin test and then you prick it with the lancet here. We have specific lancettes for SPT doing which are like with the tip is very small compared to blood lancet here. And what happens thereafter? So you are introducing the suspected allergens into the superficial epidermal layers. Sensitized individuals, these allergens will be picked up by the IgE on the mast cells. Then there is granulation and histamine release at the point of allergen leading to a wheal. And then we actually measure the induration after 15 minutes and it is compared with the positive and the negative controls. I just put an image of the lancettes for you to understand. The first one is the SPT lancetter which we use. Please note here the tip is very small, right? It may be gold, not be golden in color. Okay, it may be golden color or silverish in color. That doesn't matter. But you see the tip. This is covered one. Okay, next you see here. This is the blood lancer. Little bit bigger, slightly more bigger, but it's okay. We can use either of them. But SPT lancer really we generally use it. So what is a positive control and a negative control? Whenever we are doing this test, we should make sure that negative and the positive control is a negative control here. Actually, we use is the saline. Why? When we actually put it, the body should not react. Suppose a patient is reacting itself to saline, that means the patient is having some inherent dermatographism or some dermatological condition where the skin body is hyper reacting to any antigen you put, irrespective of the patient is having sensitization or non-sensitization. So negative control is saline. What is the positive control? The positive control is the histamine, which is 10 milligram per ml, which directly induces a cutaneous wheal and flare response. So it is said that mostly the saline will be around 0 to 3. Whatever is the saline value, the wheal diameter plus 3, at least histamine should be plus 3. That means you are introducing the histamine, body has to react. Otherwise, that is not correct. That the body is not reacting means there is something is wrong. So you cannot do that or you cannot interpret that skin test. So we need to have a positive control. We need to have a negative control. So positive control is histamine, negative control is saline. So when we actually interpret the results, I repeat again, plus 3 or more. It should be there compared to saline. Saline is 2 means 5 is abnormal. Okay, suppose saline is 3, then 5 millimeter of the tested antigen will be abnormal. Any value more than, suppose saline is 3 millimeter, you test for dust mites and you get a value of 3 plus 3, that is more than 6 or more than that, it is positive and we can say the patient is sensitized to dust mites. So here are some FAQs. Can you skin test a child? Yes, sure, we can skin test a child, but what is the minimum age? Generally, we do it after 1 year because then is the time when all these immunological things are all developed. And what is the site of testing? We can test it multiple areas. You can test it over the forearm, upper back in smaller children. So in children, they'll be very apprehensive when they see this. No? So if you feel the child is small and they are apprehensive, you can do on the upper back. It's a very sensitive area. Okay, you get the test. Generally, we do on the forearm. How many STs you do? This is generally we do approximately 10 or less than 10, but that depends. There are people, centers which we do around 20, 30 and all. But if we can actually pinpoint your antigens from the history, then you can do a test pertaining to that antigen. So there is no much correct number regarding it. But for children, generally we do around 10, 12. So why do you want to do skin test a child? That is to rule out the sensitizations. And but you need to treat the skin test? No need to treat the skin test, but you need to treat the child. So what about this blood test called the immunocap? Whether it is better or not, but it is not exactly better. We will just see this one. So you can actually see this is one skin test which we did. In this, if you see, you can see this first. This is the saline. This is not reacting. This is a histamine. You can see a very good reaction here. The 4 and the 5, these are the desmite antigens which we have put, and the person is actually has sensitized to this desmite antigens. So this is another skin test. Again, you can see saline and histamine is not reacting. Saline is reacting, histamine is positive or not. Yes, we have got a good reaction. Here again, 4 and 5 plus we have actually put some moles like aspergillus and penicillin. Again, they are reacting. So this person is sensitive not only to desmite antigen but also to moles. So there are certain contraindications for the SPT, that is like diffuse dermatological conditions, then severe dermatographism, if the subject is not cooperative, a subject unable to cease antihistamine or other interfering medications. And there is a related contraindication, that is persistent, severe or unstable asthma. That means like when you introduce and suppose anaphylaxis happens and the breathlessness may increase. So that is there. So pregnancy, because of the small risk of anaphylaxis with hypotension and uterine contractions, they are not relating on babies and infants, and patients on beta blockers. Why exactly patients on beta blockers relating contraindication? It is because this if the patients are on beta blockers, that may actually blunt the response to adrenaline when such a reaction of suppose an anaphylaxis happens. Okay. I hope you understand. Suppose an anaphylaxis happens and you give an adrenaline and the patient is on beta blocker, it may blunt the response of adrenaline. That's why. So this is immunocap, which dictates a free IG, and more than 0.1 is taken to be abnormal. And immunocap is specifically preferable in widespread skin disease, patients on immunosuppressants, uncooperative patients, and soon after anaphylaxis. So now we need to decide whether we should do a skin test or whether we should do a serum IgE. So if you actually see serum specific IgE, it will take around 48 hours for the results, whereas the skin test will hardly take 15 to 20 minutes. The patient satisfaction, definitely they are seeing in front of their eyes that their body is reacting, means then they will be more convinced that the patient is having allergy. Clinical relevance also is more for skin prick test, because when you do a panel of tests, many a times you will get so many results which you also don't know how to interpret. Cost is also comparatively lesser in skin prick test when we actually do it. For each allergen, it will be 100 to 150 rupees only, whereas total of specific IgE will be around 1,300 for one allergen. Also, it will be a little more costly. And in case of high IgE, total of specific IgE, it will show a falsely high serum IgE sometimes. And whereas in skin prick test, the results will be generally true. So suppose you get results where the specific IgE and the total IgE is normal. See, all are less than 0.1. You can take the patient and we can manage the child as non-allergic. Suppose specific IgE, the main thing is specific. There's no point in doing a total IgE. That is you can actually do it along with specific IgE, but there's no point in doing a total IgE alone. Specific IgE plus total IgE, if it is both, one is elevated. Specific IgE is elevated and total IgE is normal, then patient is allergic. Specific IgE is elevated and total IgE is also elevated, again patient is allergic. But in this case, when the specific IgE is normal and you get a total IgE elevated, just put the patient under follow-up. So these are certain studies which actually, all the studies are actually saying SPT or skin prick test is recommended as a primary method of diagnosis for IgE-mediated allergies. So summarizing what we have learned. So we have actually understood, I think, hope you had understood the concepts of allergy. atopy, sensitization, and allergy. That's what exactly is the differences between them. Here we also discussed this about skin prick test and how you interpret the results and what are the indications and other things. So thank you so much for your patient listening and hope you have liked this video. If you have liked the video, please do like it, comment and share. Thank you so much.